Shall we start, ma'am?
Yes, ma'am.
Good evening, everybody.
Oh, okay. Go ahead.
Good evening, very warm good evening to, and a warm welcome to all the delegates and our TNFOG organizers, Dr. Amani ma'am, who's the president of TNFOG, Sampath Kumari ma'am, secretary TNFOG, and all the elite speakers of today's session. This is the 7th session of TNFOG imaging series, online monthly webinar meeting. So we'll move on to the session now. Tamil Thai வாழ்த்து and lamp light.
Malti ma'am, am I audible?
Welcome. Hi, how are you?
Am I audible?
Yeah, you are.
Thank you.
I invite Dr. Ramani ma'am, our president of TNFOG, to give the introduction. Madam is the National Vice President, FOGC, 2020, and she's got huge, many number of awards. She's the member of ICOG Governing Council from 2018 to 20, and Managing Director of Ramakrishna Medical Center, LLP, and Janani Fertility Center. She's been the chairperson of Endometriosis Committee of FOGC 2014 to 2016, patron for Indian Fertility Society in South Tamil Nadu chapter, patron and president 2024 of TNFOG, executive committee member of Endometriosis Society of India, editor of FOGC GCPR Endometriosis in 2017, national corresponding editor Jogi, and she's won gold medals in UG and 10 gold medals in UG and PG.
Radhika, you stop with that.
Ma'am is a great teacher.
Good evening, everybody. It is my great pleasure to welcome all of you for the 7th series on imaging sciences that has been conducted by Dr. Malti Prasad as a coordinator on behalf of the Tamil Nadu Federation of Obstetrics and Gynecology. Today, I think they have taken up a very, very important topic, that is cardiac anomalies. Though we have 1 to 3% of total anomalies, congenital anomalies at any time in the fetus, less than 1%, say 0.5 to 0.6% are also the incidence of the congenital heart disease. And among the congenital heart disease, many of them can be picked up by a very early trimester scan itself. And then again, rest majority can be picked up by the cardiac scanning that is being done along with the anomaly scan. So by this, the advantage is many of these anomalies can be lethal So that can be picked up at a very early stage and can be terminated. And even if they appear some anomalies, these are not lethal, the patient can be shifted, the baby can be shifted in utero to the centers where there is facilities for immediate cardiac intervention. So that is the main focus why we should understand about the congenital heart disease. And today we have great speakers on this particular topic, Dr. Sinesh Kumar, Dr. Manikandan, Dr. Agarwal, and other person who are going to deal with the varying topics in the congenital heart disease. So my wishes to you, all the speakers, as well as the organizer, Dr. Malti Prasad, for this very important one. I should mention about Dr. Professor Dibashmita Mandal, who is going to have a talk on counseling in cardiac anomalies. I feel this is very, very important because most of the patients, the moment we say that their fetus has got a congenital cardiac anomaly, say even it could be a minor thing like an AST or VST, they are so much upset. So it is the way which we counsel which patient can be taken to term and can be advised immediate surgery, the correction, or they can be followed up. So these are all some of the subtle things that should be involved in counseling. And so I think today's program will be a wonderful one. And I wish you all the best. Thank you for the opportunity.
Thank you. Thank you, madam.
I welcome Professor Dr. Sampath Kumari ma'am, who is the secretary of Tnfog. She has been the professor and HOD of OG, and she's now the current professor and HOD of Sri Muthukumaran Medical College Hospital. And welcome, ma'am.
Thank you, Radhika, for the
Thank you
nice
for the
word.
opportunity, ma'am.
See, today there is a conference going on in Calcutta on television fetal imaging type. See, from TNFOG, really, I welcome all the faculty, speakers, and the panelists and everyone. And the committee chair, Dr. Malati. Dr. Malati Prasad is doing a wonderful work on this imaging series. Every month, third Saturday, she is conducting the webinar on imaging sciences, mainly with the fetal medicine. See, many people have come from outside to the Calcutta. They are traveling. See, sitting in the home, you can learn a lot of things from the webinar which Malati is conducting. See, depending on this, we are going to make it as a certified course, training course. So I request all of you to join every month for this series. And congrats to Dr. Malati and her entire team and our MOC Radhika Kauri. Thank you. On behalf of TNFOG, I welcome you all. On behalf of TNFOG President Dr. Ramani Madam, who also permitted us to conduct this meeting. Thank you. All the best, Malati.
Thank you.
Thank you, madam. Thank you.
All the best.
Very important topic on fetal echo, and we're going to make it very, very simple for every one of us to understand, not get into a lot of details. And hi, Dr. Aditya, hi. Good evening. So we have eminent speakers, Dr. Manikandan, Dr. Sini, Dr. Radhika, Dr. Devashmita, and we have a geneticist who's going to talk on genetics and cardiac anomalies. Very, very important. I think all of us should know which patient needs what test, which lesion requires what test at that point. So Dr. Bhavna Agarwal is a very eminent geneticist who's going to enlighten us on the genetic aspects of the cardiac anomaly. So this short introduction, this Dr. Radhika is going to say.
Thank you, Malati ma'am. This is a wonderful initiative, very useful for all general gynecologists and obstetricians. We'll move on to the session now. I welcome Dr. Manikandan sir for this session on counseling in cardiac anomalies.
Basic echo.
Okay. Sorry. Dr. Manikandan sir is going to talk on basic echo for obstetricians. And he's done postdoctoral fellowship in fetal medicine, Mediscan Systems in Chennai. And he's been the former was professor of Obsum Gynae, JIPMER. And he's a research fellow in fetal medicine, King's College Hospital, and special training. He's done a special training under National Teacher Training Course for teachers of higher education in JIPMER and statistics and epidemiology training from Harvard, quantitative methods in clinical and public health. And
Madam. Madam.
said he owns his hospital. It's a lead consultant in fetal therapy, fetal medicine, founded KNCH in Coimbatore and also KEM in Pune. He's a visiting consultant, visiting professor in perinatology in Pondicherry Institute of Medical Science. Welcome, sir.
Thank you, madam. So, can I share the screen? Yeah, I think I'm able to share the screen. Is my screen visible?
Yes, sir.
All right. So, thank you very much once again, TNFOG team, Malati madam especially, and the wonderful team of TNFOG persistent in academic. It's very delightful and very inspiring at the same time. Now, I'll keep it very short. In 20 minutes, we don't expect to become experts from being obstetricians to diagnosing cardiac. It's not possible. But what we can do is understand that 4 plus 3 is equal to 90. And this is the mantram that we are going to do for the next 15 minutes. Basic echo for obstetricians, we'll focus on 3 views, and these 3 views we will be able to tell whether we have to refer it to a specialist cardiac scan, let's say a fetal echo. All right. So these are the planes that the ISUOG tells us to take during a routine cardiac imaging, but that applies to if you are an imaging specialist and you are going to give out a report that has a legal standing. For those people, this is not the talk. I have a separate course on advanced fetal echo. We can go and do there. But this is for the obstetricians who does growth, who does non-target scans and, the biometry scans. Critical to understanding this is this movement of the probe. Hold it steady, hold it straight, don't rotate, don't twist, and have a gentle sweep across the baby. On the screen, the baby must be shown in cross section. Now, once you take that sweep, freeze 2 images, one at the level of the stomach, the other one at the level of the heart. At the level of the stomach, you see the stomach obviously. Here, you see the spine posteriorly. So, automatically, this is posterior. From the spine, go anti-clockwise if the baby is in a head up position, that is breech position, and you will meet the left half of the fetal trunk. So identifying the left side is the first step in cardiac examination. Once you identify the left side of the fetus, look for left-sided structure, that is the stomach is there on the left side. Major portion of the heart should be on the left side. So we say that the heart is located normally. This is the first step. Now try this. Now the baby's head is down. I have written here on the top. It's the other way. So from the spine, identify the spine, go clockwise. And that half is the baby's left side. So when the head is down, clockwise is left, head is up, anti-clockwise is left. So always think, where is the baby's left side? So this is step 1, and this happens at the level of the upper abdomen, this one. So this is the summary of determining left side of the fetus. Once we determine left side of the fetus, we are going to ask, is the stomach and the heart on the left side? If yes, then that is a normal situation or situs solitus. Now let's go to the next image that you should take. Where you have come to the heart level, freeze, roll back, frame by frame. You should be able to see the 4-chamber view of the heart. This is the 4-chamber view of the heart. The heart occupies somewhat in the middle towards the left. you see a left lung which is bright, right lung which is slightly bigger and bright. These two are brighter than the heart. The heart contains the blood, so it will appear dark. There will be four chambers. This is the atrium, and these are the ventricles. This we have already identified this as the left side. So this is the left atrium and the right atrium. This is left ventricle and the right ventricle. Each of these chambers will be roughly corresponding in size to its counterpart. Atria, ventricle and ventricle will be, by eyeballing, you will be able to tell that they are somewhat symmetric. Now, these are the AV valves. They are closed. You can roll the frame slowly, one by one, the cine loop in the machine, and you can see them opening and closing. So open, you cannot see the valve, and it closed, it forms a nice dome. Now, the orientation of the fourth chamber will change depending on the position of the spine. In the previous, you see the spine was posterior, so the fourth chamber was upright. The spine becomes lateral. Here is the spine. The fourth chamber becomes like a sleeping position. So standing position, sleeping position, upside down position, it can be in any position, but the features are going to be constant. We have four chambers, two atria, two ventricle, and the atria will be symmetric to each other. Ventricle will be symmetric to each other in terms of size. Now go back one step. Now you see the left ventricle is a bullet-shaped structure, smooth at its apex, whereas the right ventricle usually shows some echogenic material in the apex, and these are trabeculae. And one of them may be very prominent and will be called as moderator band. We need not know all these in-depth details. We have to know that right ventricle looks triangular and left ventricle looks like a bullet. Similarly, the left atrium appears to be like pulled back because of the insertion of the pulmonary veins, whereas the right atrium will have a nice bald head. So the right atrium will be like this, whereas the left atrium appears to be like a dog-eared appearance. All right. So once we have this pattern in mind, we should always get the pattern in mind, because pattern recognition is important for non-cardiologists in identifying if there is an issue. All right, let's go to some more situations. Now, here you see the spine is posterior. This is head up. So this is the left side and the left atrium, right atrium. Size is okay. Left ventricle, right ventricle, size is okay. And the shape of the ventricle is also okay. The valve is completely open and therefore has disappeared, also okay. Now, once you do that, then what you do continue the sweep even further up. So you will find all these things. Now I will go through one by one. So once you have four chamber view, then just continue sweeping up. You can see that from the left ventricle, a small vessel starts and coming out. That's the aorta normally. And you keep sweeping up. From the right ventricle, again a vessel comes out. That is the pulmonary artery. We don't have to worry about all these things. We are going to land up at this stage. This is far high above the fourth chamber view. We have come, but parallel. The transducer has not tilted, just come straight up. Now we see that there is a big dash, a big dot, and a smaller dot. So there is a dash, dot, dot, a dash, dot, dot. We already saw that this is the left side of the fetus. So the dash is on the left side. The bigger dot is in the middle and the smaller dot is in the right side. So it ends up there. Now go even further. This is not strictly required for non-cardiology obstetricians if you are not reporting. you will see that the middle dot has now become a dash again. So this is at the level, highest level, this is the transverse arch. That is the aortic arch. We will stop here. This is our area of interest. So we saw the fourth chamber. Now we are going to, this is called the three vessel view. So the first dash comprises of the pulmonary artery here, which continues as the ductus arteriosus. The neighboring bigger dot compared to this dot is the ascending aorta cut across. And this dot to the right of everything is the superior vena cava, again cut in cross section. So dash dot dot, fourth chamber dash dot dot. So that is the fourth chamber view. This is the three vessel view arranged in this fashion. So this pattern we should recognize. All right, so the still image is always better when you are beginning to do a cardiac scanning. Now, if you have color, you have the option of turning on the color and visualizing that the blood enters and fills the ventricle. But if you don't have, or if you're not comfortable in color immediately, no need to switch it on. When you become an advanced user, you can start twisting the probe and get the aorta like this, like a long tube, and the pulmonary artery like this, but these are not for today. All right, so let's see some of the patterns which you should recognize. This is the fourth chamber view, all good. The atria are good, ventricles are good, but we see a bright dot in the middle of the left ventricle. This is a common scenario called echogenic focus of the left ventricle. Nothing to be done. If they have already done a first trimester screening and they are negative, you can ignore this. Now, where you should not ignore is if it is not a dot and if it looks like this is a cardiac tumor called rhabdomyoma, and this requires further evaluation. So at the beginning, when you see a dot, refer for an echo. When you have acquired good enough skill to differentiate the dot from a tumor, then for this indication, you need not refer. Now, look at this image. This is the normal I have put for reference. Four chambers are there, left, left, right, right. Here, we see that left atrium is there, right atrium is there, right ventricle is well formed, but left ventricle is diminutive, contracted, hypoplastic. It's not seen well. So this is a problem. So the fourth chamber view, not good. Why not good? One of the chamber is diminutive, so not good. So this is a bad thing happening here. Now look at this heart again. This is the reference heart once again. I have flipped it so that it will match this image. There is a left atrium, there is a left ventricle, right atrium, right ventricle. This is the normal pattern. Look at this here on the right side. Let me activate the laser. On the right side, you can see that left atrium is all right, right atrium is all right, left ventricle is open and all right, but right ventricle, similar to the previous one, this ventricle is diminutive and almost obliterated. So once again, we see that there is a deficiency or lack of cavity or asymmetry of the chamber. So here, only three chambers are present. The fourth one is diminutive. Now, what happens in both these cases? This itself is abnormal. This, when you see the fourth chamber itself, you know it's abnormal. You can straight away refer for a fetal echocardiography and ask for a perfect diagnosis, including prognostication markers. In both these cases, when the fourth chamber is abnormal, you will also get a bad three vessel view. The three vessel view for reference is here. We see the long dash dot dot. Here you see a dash is there, but there is only one dot. So the other dot is missing. So this was the case where the left ventricle was diminutive. So it's a HLHS. We don't have to go into the details of the actual cardiac diagnosis. Now, in this one, the one on the right side, you see the dash is not there at all. You can see a dot, you can see a dot. The long dash is missing. So this is the case corresponding to this image. So the right ventricle was diminutive, obliterated. The dash is missing. I said before, the dash represents the pulmonary artery. So something wrong here. This the final diagnosis will be pulmonary atresia. Now look at this image. So in the fourth chamber, if you don't find a cavity or the cavity is obliterated, that's a definite bad sign. Now let's go to this image. This is the comparison image, normal. You see the four chambers beautifully placed. But look at this image. You see the left atrium is present and left ventricle is also open nicely, but they are smallish compared to the right-sided structures. So this is a classic right-left asymmetry. Normally, a slight degree of right-left asymmetry is okay in the fetus, is physiological. When it is exaggerated, then we must look for answers. Either the right is giving off more blood, is handling more flow, or the left is handling less flow. This is the interpretation from this fourth chamber. So I know when I look at this fourth chamber, there's something going on. So I need to now look at the fourth chamber above this, that is the great vessels. So this first condition is, you can see that both tubes, the great arteries, arise from the right ventricle. So this is a condition of double outlet right ventricle. You don't have to get this. If you pick up here, that's far more enough. Once you go into this, then we need to spend a lot of time to prognosticate, to find out how the baby will fare after surgery and everything. In real time, it looks like this. Two vessels coming from the same ventricle. All right. Now, right-left asymmetry. Look at the pass view, that is the three-vessel view. The three-vessel view, also called as the pulmonary aorta SVC view. So, the pulmonary artery is bigger. The aorta is smaller than it should be. SVC is all right. Now, this is also a problem. There was asymmetry at the fourth chamber and there is asymmetry at the vessels. So, the most likely diagnosis is what shown here. This is a coarctation. So once you see the three vessel view also abnormal, where the dot is much smaller than this dash, then it is a abnormal three vessel view. Normally, the pulmonary artery, this bit is the pulmonary artery, should be very slightly bigger than the aorta. Not this is like double the size. So this is abnormal. All right. Now, once again, we'll go to one more pattern in four chamber view. This is the four chamber view for reference. It's normal, but look at this four chamber. The two atria are somewhat not okay. And then the two ventricles are okay. But look at the center of the heart. If you see the intersection of the valves and the ventricular septum, you see that there is a nice crux, a cross-shaped area. But here there is a big hole, a large hole in the center of the heart. So this is an AVSD. This is another pattern of abnormality that you should pick up in the four chamber pattern recognition. So four chamber, so many problems we can pick up. 60% of major cardiac defects will show some problem, some clue in the fourth chamber, some of them very obvious like this. Now, this is again a four chamber view. Let's compare it to the control view. All okay. There is a left atrium, right atrium, left ventricle, right ventricle. There is a good crux. They are all symmetric. All the chambers are good. Excuse me. So this is a normal looking four chamber view. Now let's go to the pass view or the three vessel view. This is for control. There is a dash dot dot. If you see the dash dot dot here, the dash is very diminutive, is small, is a small caliber. The dot, the middle dot has become much bigger. Now that means there is something going on between the connections. So the aorta, which is the center, is receiving a lot of blood and the pulmonary artery is receiving very little blood. So this is a problem and this will ultimately turn out to be a tetralogy of Fallot, where because of the overriding, aorta will get more blood and because of the stenosis, pulmonary artery will get less blood. So you don't have to go into those images. It is sufficient if you pick this up and say, okay, even though the fourth chamber looked okay, this is not okay. and this requires a referral for a diagnosis and prognostication. Once again, the 4-chamber looks relatively okay, and this is the pass view. This is the dash, big dot, dot. But look here, just to the left of the dash, there is another dot. So you see, instead of 3 vessels in this 3-vessel view, you are seeing a 4th vessel. That is also not correct. So we need to know what is this 4th vessel. In most cases, it will be a innocuous left SVC that persists. Nothing to worry. In some cases, it could be a dangerous vertical vein of total pulmonary anomalous venous connection. Again, no need to go into the diagnosis. We must recognize this pattern. Once again, you can see that the dash, dot, dot, and there is another dot here, which I will show you in just a moment. Yes, you can see nicely that this is the extra vessel that comes in this view. All right, now let's go to the next pattern, the normal 4-chamber view. Once again, we see a normal 4-chamber view. The atria, the ventricle, while open, symmetric, all good. Now then go to the pass view. What do we see? We see a dash, but this dash comes somewhat inverted. It should have come straight like this. It comes like a reverse boomerang, isn't it? Curved like that, and there is no other dot. There's only one dot here, that is the SVC. So you don't see a typical pattern here. So this again, so there is a problem in the orientation of the great vessels when it comes out of the 4th chamber. This ultimately turns out to be a TGA. To demonstrate a TGA requires a lot of skill and training, but to pick up that this is abnormal just requires that you do a gentle sweep from the 4th chamber towards the fetal upper thorax. All right. So to sum it up, these are the patterns that you should remember. A 4-chamber view showing 4 chambers, a nice crux, and the atrium appearing like a dog ear on the left side and bald on the right side. The left ventricle like a bullet, right ventricle triangular with echogenic apex, and all symmetric corresponding chambers. Then you move up. On the left side, you should see the pulmonary artery, which continues like a ductus arteriosus, thereby producing a dash. Near that, almost similar size aorta, slightly smaller. This is not 1:1, but 1:1.2. So slightly smaller, not very small. And then there should be a SVC. So these two pattern, if you recognize the 4 and the 3, you will be able to exclude 90% of congenital heart disease, and almost all of the lethal, the very bad ones you can exclude. So that is why I told at the beginning, 4 plus 3 is 90 in congenital heart disease detection. Thank you.
Thank you, Dr. Manikanta. I think it was a very crisp and very clear, informative, that most of the congenital anomalies can be picked up by a 4-chamber view and 3-vessel, right? You agree?
Yes, madam. So also I wanted to keep it very simple for the obstetrician. There is no need to go into too much detail. If we find anything abnormal in these views, then simply make a referral for a full-fledged echocardiography. Thank you very much.
Thank you, Dr. Manmohan. On to the next one. Any questions in the chat box? Madam? No, I don't. Okay. Thank you, Dr. Manu.
Thank you, madam.
Yeah, thank you, sir.
Shall we move on?
Please.
Thank you, Manikandan sir. So the next speaker is Dr. Sineesh Kumar. CV, please. Sahiti. Sahiti.
Sahiti.
She's not
Uh,
here.
Can I allowed to be?
Yes,
Am I
sir.
audible, ma'am?
Yes,
Sorry for
sir.
my voice here.
You're
Can you
audible.
allow me to share the screen?
Yes, sir.
Yeah, you
we'll-
can.
Ma'am, I will share the CV, ma'am.
Sorry.
Dr. Sinish Kumar, sir, is from is done his MBBS, MD, OG, Independent B, and MFM and MSc Clinical Genetics. And he works as a consultant in fetal medicine and fetal therapy, ARMC Aegis Hospital, Perindalma and Aster MIMS Hospital, Kottakkal, Kerala. So he's done his specialist training and fetal medicine, maternal medicine from Simar, Edapal. Masters in Maternal Medicine and Fetal Medicine, Barcelona, MSc Clinical Genetics in Chinese University of Hong Kong, PG degree in Fetal Cardiology, University of Barcelona, and Trial Fellowship in Maternal Fetal Medicine in Italy, and training in fetal therapy, Sri Raj Hospital, Bangkok, training in fetal cardiology, Royal Brompton Hospital, London, and he has 26 publications in national and international peer journals. Special interests are fetal genetics, fetal therapy, fetal cardiology, and fetal medicine training. Welcome, Sinish Kumar, sir. We are waiting for your talk.
Thank you, Radhika, ma'am. Maybe can I share my screen?
Yes, sir. Please.
So at the onset, let me thank Malti Madam and team TNFOG, not for inviting me, but for conducting such wonderful webinars in a persistent fashion. I mean, this matters a lot for the obstetric community, which has to think beyond deliveries, beyond hysterectomies, and they should know. They should all of us should now have a basic knowledge of ultrasound for day-to-day practice. My topic, if Manikandan presented on second trimester fetal echo, my topic is even difficult. I have to, teach a very, very difficult topic to the obstetricians that is on the first trimester fetal echo. So we are all scientists. So let us ask some basic questions first. Why do we need a first trimester fetal echo when we have that elaborate second trimester fetal cardiac examination? If at all it is required, who are the candidates for a first trimester fetal echo? How to do it, and let us also see some practical scenarios where they can be applied well. So, what is the rationale for a first trimester fetal echocardiography? Or in other words, why do we need to do it? Now, we know about the total congenital cardiac disease burden. It is the most common cause of neonatal mortality. The incidence is very high. It has a strong association with extracardiac anomalies, chromosomal, and genetic syndromes. And prenatal diagnosis aids in perinatal management and improves outcome. All this is well known. When we come to first trimester fetal echocardiography, some important things that we should remember is the fetal heart is actually already formed by 10 weeks. So if there is a major cardiac anomaly, it is already present during your NT scan. In fact, more than half of the cardiac anomalies could be detected in the first trimester, and these are the cardiac anomalies which can have a major say on the perinatal outcome. There are some strong indirect markers which can provide you a strong suspicion of congenital cardiac diseases such as NT, abnormal NT, altered TV, ductus, etc. Once a congenital cardiac disease is suspected or diagnosed in the first trimester, it gives ample amount of time for counseling the woman and her companions. There is an adequate time to do the genetic workup and wait for the results to take a call on whether to continue the pregnancy or not. The parents have enough time for a decision making because this is a very emotional decision that they have to make. Also, if termination of pregnancy is required in the first trimester, we all know that it is medically and psychologically safe. But then there are some also cons against the fetal first trimester cardiac assessment. It's not all cardiac anomalies can be detected in the first trimester. In fact, some of the anatomical landmarks, such as the interventricular septum and mitral tricuspid offset, may not develop by 14 weeks. The detection rate varies according to the type of cardiac anomaly. So some cardiac anomalies can be rarely diagnosed, such as univentricular heart, whereas for conotruncal anomalies, this is limited. first trimester fetal echocardiography is heavily dependent on operative expertise. There is a very long learning curve for it. Also, it requires a very good quality ultrasound machine. It could be technically challenging because fetal position, maternal habitus, especially we know for the woman from the southern region of India, how difficult it is. Moreover, more and more anomalies can evolve as the pregnancy continues, and this can change the prognosis, requiring need for a review scan. And a very important thing in medical science is a cost-benefit analysis. And to this day, and to this the time of presentation, a cost-benefit analysis of first trimester fetal echo has not been done. Nevertheless, IUCOG, which is the society that is providing guidelines for everybody in the imaging field, has come out, has given a special section on first trimester cardiac screening in their revised guideline, which was published in 2023, where they said it might not be mandatory, but when available in the form of expertise and equipment, it can be readily offered to all the women. In fact, they have also explicitly set out the criteria of how to do, or the key recommendations on how to do a first trimester fetal echocardiography. Now, let us assume that now we are convinced that we can do a first trimester fetal echocardiography. The next question is, does all women require it, or do we have a special cohort which requires a fetal echocardiography? Now, traditionally, especially within the obstetricians, these are the important indications for doing a fetal echocardiography. But only 10%, less than 10% of prenatally diagnosed congenital cardiac disease have any of these risk factors. Therefore, the traditional risk factor-based approach that we use in second trimester fetal echo cannot be used in first trimester fetal echo as well. When we come to first trimester, there are some strong markers which indicates that there could be an underlying congenital cardiac diseases such as an increased NT, presence of a hydrops, reversal of A wave, abnormal TR, abnormal cardiac access, monochorionic pregnancies, and infections. So in your obstetric practice, if any of these things or any of these parameters have been reported in a first trimester target scan, then such a woman should be readily referred for a first trimester fetal echocardiography. In fact, a lot of studies have shown how important these parameters are. As can be seen from this bar diagram, the incidence of congenital cardiac diseases increases exponentially as the value of NT increases. So you can see that the burden of NT when the burden of CH congenital cardiac diseases when NT is more than 3.5 is so huge when it is less than 3 or even less than 2. Similarly, abnormal NT and ductus venosus can also indicate an underlying congenital cardiac diseases. In fact, various studies have shown that up to 1/3 to 1/5 of congenital cardiac diseases have an abnormal ductus venosus in the first trimester, either a reversed A wave or an elevated DVPI. In fact, this last study that was published recently showed that almost 30% cases of prenatal diagnosed congenital heart diseases had an abnormal NT, and about 28% had a reversal of D wave in them. One important marker that has also come in the recent years is cardiac access. A study which was published in 2015 showed that 3/4 of fetuses with abnormal congenital cardiac diseases had an abnormal access in the first trimester. In the study, the normal cardiac access was about 34 to 57 degrees, slightly different from the values that we use in the second trimester. In fact, this basically summarizes how the first trimester markers such as NT, DV, and TR can predict an underlying congenital cardiac diseases. Now, having understood this, like Manikandan described the second trimester protocol for cardiac evaluation, do we have a protocol for doing a first trimester cardiac evaluation? Yes. There are important machine settings, the details of which I'm not going into, but if you are an obstetrician doing ultrasound examination on in a persistent manner, then you can ask your application specialist to improve your first trimester cardiac settings so that you could effectively do a first trimester cardiac echocardiography. Now, basically, this requires adequate magnification, use of the highest possible transducer with the highest possible frequency, magnification so that the 4-chamber view occupies at least 50% of the image, increased dynamic contrast and gain. Also, the first trimester cardiac diagnosis is heavily dependent upon the use of color Doppler, and therefore optimum color Doppler settings should be utilized in the first trimester to effectively diagnose congenital cardiac diseases. Now, the views that one takes for fetal cardiac evaluation depends on whether they are done on a routine basis or they are done for a referral, that is high-risk woman. So for a low-risk woman, it is enough that one focuses on taking the rate, that is a fetal heart rate, situs, if that is possible. Remember, situs evaluation in first trimester is not as easy in the it's not as easy as in the second trimester. Evaluation of the four-chamber, both in the grayscale and color Doppler, and evaluation of three-vessel trachea view. Okay, this is a basic algorithm or basic approach which can be used for first trimester cardiac evaluation. For the fetal medicine specialist or other imaging specialist with special expertise in first trimester cardiac evaluation, in addition to all these views, they would be evaluating the outflow tract views also, and sometimes the sagittal views of the fetal heart. When to do these examinations? Now, not just for fetal cardiac evaluation, the fetal anatomy is best seen at 13 weeks of gestation, whether it be the kidneys, whether it be the limbs, the digits, the brain. It is well known now that the best time to do a first trimester targeted evaluation is 13 weeks, and the same thing applies to cardiac evaluation. Now, as shown in the study, which was published in 2017, it is clearly seen that almost all the basic and advanced cardiac views are well visualized at 13 weeks of gestation. So this is very important in the sense, if there is a pregnancy in which there was a congenital cardiac disease, in the future pregnancies, the NT scan can be postponed to 13 weeks of gestation instead of doing at 11 to 12 weeks of gestation. Now, as I said, the basic views, one of the important basic views is looking at the situs in first trimester cardiac evaluation. Now, as I said, unlike in the second trimester, this might be difficult. For the obstetricians who are doing scan, it might be easy for them to just see whether the stomach, which is this structure, and the cardiac apex are in the same level. So either that could be a normal situs, which is called as a situs solitus, or it could be a situs inversus totalis, both of which have low incidence of cardiac anomaly. So it is much more sinistrous if the stomach is on one side and the cardiac apex is on the other side. Now this shows the grayscale and an optimized color Doppler settings, which shows biventricular filling. Now the color settings have been optimized such that both ventricles are filled equally. Now this is a very, very important view when it comes to first trimester cardiac evaluation. This is the evaluation of the arches. So in this, one aims to look at the antegrade flow in the ductal arch, which is this, and the aortic arch. So it is very important that they converge and there is antegrade flow in both these arches. So most of the time, they will show the same color. Now, showing outflow tracts requires a much more greater skill and a learning curve. And in the normal color Doppler settings, it might be difficult. But newer machines have this modality, which is called as a microvascular flow. In GE machine, this is called a slow flow HT, which might be useful in depicting the LVOTs and the RVOTs more explicitly. So if there is a previous pregnancy, or if there is with a congenital cardiac disease, or any risk factors pertaining to cardiac diseases, then it is important that the LVOT and the RVOT are properly assessed in advanced color settings such as slow flow. As we have already discussed, the indirect markers should also be paid attention to. So this includes evaluating for the tricuspid regurgitation and ductal venosus. For this, the Fetal Medicine Foundation UK guidelines, which I assume has been presented in an earlier Tnfog class, should be strictly adhered to. In addition to this, one should look at the axis, which is for the steps for which are basically same as in the second trimester. Now, more often we do this more subjectively than explicitly taking the cardiac axis. So we have now seen that first trimester fetal echocardiography is of great utility. We have seen how to do it and what are the basic and the advanced views. Let us see some case scenarios where we could use this to diagnose some congenital cardiac disease. So now this case was referred as an increased NT, and on cardiac evaluation, we can see that there is some problem with the four-chamber view. Also, the filling doesn't show two distinct fillings or two distinct separate inflows. In fact, there is some kind of merging which is happening near the apex. On further evaluation, it is also seen that the three-vessel trachea view is also not obtained. In fact, you see a single outflow which is coming from the right side of the heart. And again, this picture again shows the mixture of the two inflows that is happening at the center of the heart. Now, this case was evaluated later, also at 16 weeks, And this was actually a case of atrioventricular septal defect, and with a single arterial outflow of the aorta, there was pulmonary artery atresia and tricuspid atresia. So this enabled for adequate time time to counsel the couple, and Korean venous sampling was offered to test for to do a genomic analysis of the fetus, and the couple again opted to have a re-evaluation at 16 weeks of gestation, where the findings were confirmed, and they opted for termination of pregnancy. Now, this case is offered as an hydrops and occipital and encapsulocele, both of which can be seen here. The encapsulocele, the hydrops here. And when we looked at the cardia of this case, we can clearly see two inflows here. There's some issues here, like the axis is much more towards the left than normal. And when we evaluated further, we could see that both outflows were actually coming from the right side of the heart, as can be seen towards the later part of this clip. You can see that both outflows were actually coming from the right ventricle. So this additional anomalies, there were bilaterally abnormal lower upper limbs, there was fixed flexion deformity, poorly developed digits, there was double outlet right ventricle and mitral atresia. This patient, after counseling, opted for CVS, where we did a basic QF-PCR with chromosomal microarray, and this turned out to be a trisomy 18. Now, this case was referred to as an increased NT. One can clearly see that the NT is increased. The baby is totally looking abnormal. There is a micrognathia here as well. And on evaluation, on 3D evaluation of the fetus, we could see that the Fox survey was present. There was actually a polydactyly which was present here, and bilateral cleft of the upper lips. Now, this had a very unique findings, which might be of useful to the budding fetal medicine specialists who are listening to this case. So one can see that there is a reversal of A wave in ductus venosus, but when the umbilical artery is evaluated, you can see that there is a reversal of the diastolic component in the umbilical artery. Now, this we know is very common in cases of fetal growth restriction in second and third trimester, but in the first trimester, if you get a reversal of the diastolic component in the umbilical artery, this is pathognomonic for a very specific cardiac anomaly, which can be seen here. Now, if you look at this is a 3-vessel trachea view. You can see that the blood is also flowing towards the spine. It is also moving away from the spine. That is, there is to and fro motion of the blood, and one can also see that the branch arteries are dilated. The branch pulmonary arteries are dilated. So this is a very classical case of a particular type of tetralogy fellow, which is called as the absent pulmonary valve syndrome. Again, in this case, there was adequate time for counseling. The couple had enough time to think, and they opted for Korean venous sampling. And as was expected, this case turned out to be trisomy 13. So this is a single, video clip which shows an abnormal 3-vessel trachea view. One can see that the two arches, instead of converging, they are forming a kind of U around the trachea. So this case was again evaluated at 16 and 21 weeks and was confirmed to be a right aortic arch. Again counseled, again amniocentesis was offered, where we specifically went for chromosomal microarray, because we know that in this case we have to not just rule out Down syndrome and other common aneuploidies, but also we need to rule out Dijot syndrome. Once these were ruled out, the pregnancy could continue and they had a normal outcome at birth. So this case, as a routine scan, the NT was all normal. And when you see the 4-chamber view clip here, you can see that the LVOT there is a perimembranous VSG here, which is called as a malalignment VSG or an overriding aorta. And when evaluated in other clips, we could see that the pulmonary artery is small, but showed an antegrade flow, and the perimembranous VSD was in fact confirmed. So this is a case of tetralogy fallow with pulmonary stenosis, which we could diagnose in the first trimester. And again, counseling and chromosomal microarray was offered here, because again, in this case, besides the common aneuploidies, we have to rule out 22q microdeletion syndrome. Again, another case with normal NT. And if you see this clip, you can see that the outflow tracts are quite abnormal here. There is a large VSD. There is a very little flow across the tricuspid valve, and both outflows are coming from the right ventricle. I know for the obstetricians, this is very, very difficult to understand. But my idea of showing these clips is to create an awareness of the kind of cardiac anomalies that can be diagnosed in first trimester. Now, because of this is again a case of common arterial trunk or persistent truncus arteriosus, which could be diagnosed in first trimester, single outflow coming from the heart, receiving drainage from both the right and the left ventricle. Again, a cardiac condition which has a very high association with extra cardiac anomalies and chromosomal abnormalities. So again, counsel and testing was offered in this case. Now, to summarize, we can have a systematic, structured approach to first trimester fetal echocardiography, just as in second trimester fetal echocardiography. The only thing is, it requires a much more learning curve. That means you need to do a lot of first trimester cases on a daily basis. Rely on first trimester markers, NT, DV, TR. Even in these days, these markers remain very, very powerful. So if at all you get an increased NT, an abnormal DV, or the presence of a tricuspid regurgitation, or you doubt about the normalcy of the heart, immediately refer to fetal medicine specialist. Careful and cautious counseling is required because anomalies can evolve, that there can be a lot of false positive findings as well. So always take the help of a fetal medicine specialist and a pediatric cardiologist who has an expertise in first trimester imaging. And in general, first trimester cardiac anomalies have a high underlying burden of genomic abnormalities. So a suitable genetic test with a chromosomal microarray, whenever possible, should be offered to them than just relying on a karyotype. So this shows a simple flow chart on what to do. So all pregnancies, not low risk or high risk, all pregnancies would have a scan. Will have an NT scan done close to 13 weeks, where we would evaluate these indirect markers, and we will take this simple two, images or clips of 4-chamber and the 3-vessel trachea view. Everything normal, they proceed to the anomaly scan, which can be done anywhere between 19 to 23 plus 6 weeks of gestation. We prefer to doing at 21 weeks of gestation. Any abnormality here, refer to a fetal medicine specialist. Refer for a first trimester fetal echocardiography, where we would have a detailed evaluation in an advanced ultrasound machines, and we would be also looking at the additional views wherever possible, and an endovaginal scan would be a routine part of cardiac evaluation in those contexts. With this, I close my presentation here, and I assume that this might have been useful, or at least an awareness would have been created about the burden of congenital cardiac lesions that can be diagnosed in first trimester. Thank you so much.
Thank you, Dr. Sunesh. I think it was fantastic. You just gave us what is required for the observations. And we all know that first trimester fetal echo is much more complicated than the first, second trimester, because you need to do a transvaginal ultrasound with a very close look on the heart and wait for the fetus to take the position. Thank you very much, Dr. Sunesh, for those wonderful abnormal cases which you presented. Thank you. Any questions in the chat box? Yes. Thanks, Dr. Sunesh, for changing your time. I think you have flight at 8 o'clock. Your time minutes to come on the plate. Thank you. Any questions? Yeah. Thank you, Dr. Sunesh. We go to the next time.
Thank you, ma'am.
Dr. Joseph, yeah. Hi. You're muted. You're muted. You're muted. Mute ho gaya. Mute.
Yeah, a very good evening to everyone. I'm really sorry for not attending properly because I'm going through this kind of conference. This is Fitovision is happening. So I'll be just sharing my slides within a minute.
Welcome, Dr. Professor Devashmita Mandal, who is in charge of the Fetal Medicine Unit, Krishnaya Institute of Cardiac and Fetal Sciences.
Yeah.
And she's been the executive board member for 2020 to 22, editorial board of SFM journal, and SFM postgraduate fetal medicine course coordinator between 2020 and 2022, and secretary in fetal medicine division, Bengal Obs and Gynae Society. and she's been a management committee member and published more than 40 articles in international and national journals. Thank you, ma'am,
Thank
for
you.
coming, taking your time.
Yeah, I'm sharing my slides. Can my slide is seen?
Yes, ma'am.
It is seen?
It is seen.
Yeah. So actually, ma'am has topic given the counseling in cardiac anomalies. It is a really difficult and challenging. I would rather not going for the individual things. I'll be approaching from a very general point of view. Why we are going for the congenital heart disease counseling? Because it is almost world ranges from 13 cases per 1,000 children born alive. And it is very common basically. In our setup, if I'll count down what kind of anomalies I have went through, that is cardiac anomalies are the most commonest to be encountered basically. And the basis of early detection of congenital malformation is well organized screening of the pregnant woman also. It is not necessary that we are getting always cardiac anomaly, but cardiac screening is also very important. Even not an anomaly, many kinds of soft markers getting is also a very important part of doing a cardiac scan, what already Dr. Sini says went through actually. So fetal echocardiography is almost a mandatory right now. So if I'll go through this chart, basically, using the diagrams and flow charts are the majority should be are part of a counseling basically. Even to the patients also we can show how we should go through a cardiac anomaly scan, counseling. So the couple should go through the gestation of the pregnancy. First, it should be decided what is the true gestation of the pregnancy. Then if it is a congenital heart disease diagnosis, then about the explanations, the mode of treatment association, if at all they are decided to continue with the pregnancy, and about the genetic testing, then fetal anomaly scan. These are the things we need to go for. The genetic testing is a part of the Dr. Bhavna. She will be telling more better way. So I'm not going to detail, but about the fetal anomaly scan, it's about the explanation of lawful options. What are the things it can happen? Like if we are going for a termination or something like that, then what is the timing, where it should be, who will support them, and what should be the way out, the future. What is about the future? It's not about only the termination, it's about the future of the next pregnancy also. So if at all we are not going for any interventions, then what are the options basically? So conveying the informations, it can be through the leaflets, it can be through the clinical letter, you can write down in your pad, or you can have a format like this in your clinic, and with the contact details and everything. And the support, it doesn't mean only about the doctor who is doing the scan, it's about the sister who is also involving, it's about the geneticist who is going to involve, about the whole gamut of the people who are going to involve in this finding basically. So it is, if at all it is about the continuation of the pregnancy, then it's about the antenatal scans, rationale for the need and the routine care, the site of the delivery, education on what to expect, what not to expect basically. It's not necessary that we are going to always expect in a good way. Whenever you are telling the patients that we are going to go for expectant about of this pregnancy, but we have to at the same time tell about the thing, what are the things can culminate into the what are the things can happen to the fetus in the neonatal period as well, how we have to go through the surgery, what are the things can happen, and what kind of stays it will require in the NICU, what kind of economical burden they will went through, many kinds of things about that, because it is their freedom of choice after all, whether they should continue this pregnancy or not. So empowerment and resilience, that is very important to make the parents resilient to take over the whole decisions later on, and life with a child with a history of congenital heart disease, that they have to give information. That is very important actually. So the ultrasound scan, before providing an explanation of the findings of the heart scan, a drawing of a normal heart is also very important. How it works is provided. Like fourth chamber of the heart, we are seeing with the great vessels outflow, and how it is explaining in a very simple way. Even a fetal circulation can be drawn in a very simplified drawing, That is very important. What the normal heart goes through, how the vessels, the great vessels with the outflow tract, what are the inflow tracts, how the venuses are draining. Any layman can also understand. It's not necessary we have to go for with a very heavy languages of the medical languages. With a very proper colloquial languages also we can explain with small kind of normal heart drawing. So differences between the circulations before and after birth, that is also very important point we need to go through actually. Before birth, say foramen of how it acts and how it closes after the birth, how the circulation happened, what about the oxygenation blood that was going through the ductus venosus, but what after the neonate, the baby born. So these things has to be addressed. Even if they are layman, they are going to understand. So how it going to affect the congenital heart disease, in that way you can explain better. So this diagram is then compared to the one of the heart lesion with an explanation of the impact of the abnormalities. So this is one of the very good way of doing the counseling. So implication of the diagnosis, if you are doing a diagnosis, then what is it going to implicate? So it can be because of many types of congenital heart disease, the therapeutic approach can be also done. Like it is a bradyarrhythmia or tachyarrhythmia. So intrauterine therapy can be done very easily. So those kind of things we need to go for. Or it is a very much congenital heart disease with 233 anomalies. So how the quality of life will be there? So that has to be the true facts has to be explained properly to the patients and their relatives. So potential associations of the cardiac lesion also we have to explain. So like a congenital heart disease can be most commonly associated with cleft lip, cleft palate. That is also there. Many kinds of skeletal dysplasias can be associated with cardiac lesion. Many kind of other kind of things like halterum and all kinds of limb abnormalities can be associated with cardiac lesion. So those things has to be clarified. Of course, when we are going for a fetal echocardiography and diagnosing the cardiac lesion, at the same time, we know what are the other organs we have to go through. What are the other things, the full fetus we have to go through, starting from the head to toe. So what are the other abnormalities that is including everything? So we need to decide upon. And that the parenteral options comes after that only. So these are very, very important things we need to go through. Assisting families understand the future for their babies. That is most important thing. And also the same time, how you have to save your skin, the legality of the decision making, what you are going through, and it may happen, the parent may deny you later on that you have only told about the baby, but the baby had went through a traumatic experience. We have spent a crore of rupees regarding all the surgeries and everything. And so that's why we are going to see you a legal on you, legal actions against you, because you haven't only told us to go through this pregnancy and carry on this baby. So these kind of things should not happen. Everything should be very much well documented. Even if when we are doing the counseling, you can have a CCTV there also. That is not medical legal cell have actually advocated that thing, so that the both the parties, what they are going through, that can make a sense how you are going to record. So with the recording of your handwritten things that I have already explained you, and also about the whatever you are talking or whatever you are discussing throughout the thing, that can be also recorded. That is very important thing. And it is very, very important to think about how I have to continue this pregnancy. That is the most important. Whenever I am getting through the termination of the pregnancy, what are the kinds of decisions I have to make? Even through the continue, what are the points I have to continue through? So a medical physician who is going through or doing a fetal echo, they have to understand a lot actually. It's a really difficult task basically. Mechanism of progression of the fetal heart disease, they need to understand. The progressive atrioventricular seminal valve insufficiency. What the echo you have went through in the 24 weeks, that may change the implications in the 32 weeks. So that's what we need to understand. Every disease has got its own pathology of progression, and every gastration has its own pathology of own physiology of progression. So naturally the physiopathology of progression we need to understand, and we have to make them understand also. So these are the very points. First of all, you are going for the drawing of the structural things. Now you have to go for the physiological and functional things to make them understand. The progressive atrioventricular and seminal valve insufficiency, that may result in progressive ventricular dilatation also. So that is also very important to make you make others learn also. And progressive atrioventricular seminal valve obstructions may also happen. The pulmonary stenosis, what is you are going through, that can go through the atresia also later on.
that is, we need to understand. That may be with a least flow later on. The progressive atrioventricular valve, ventricular great artery, branch, pulmonary artery, and arch hypoplasia, secondary to obstructive lesions, reduced blood flow. These are the real true facts. We need to explain them. Development of myocarditis and cardiomyopathy, that things we need to explain. Like somebody is with diabetic, somebody is with SLE, somebody is with some other kind of medical disorder. So many kind of things are there. They can progress into the cardiomyopathy and myocarditis. Even an infection, intrauterine infection can lead into that. So these things we need to keep in mind. Then progressive myocardial dysfunction, secondary to structural, functional, breathing disturbances, that may lead to the evolution of hydrops and sudden fetal demise. What you have actually explained, bradyarrhythmia, the gestation of 18 weeks, that can evolve into 24 weeks with the hydrops. So these things you need to explain. That is very important. Development and progression and regression of cardiac tumors. What you have went through echogenic foci and you have explained that can culminate into a cardiac tumor later on. So those things also you have to be very particular how these things are going to explain basically. The rhabdomyoma, you had seen in the left ventricle that is floating around a rhabdomyoma with sitting on a left ventricular wall. But you may see there was one rhabdomyoma, but with gestation in the later gestation, you may see almost 4 rhabdomyomas. Rhabdomyomas actually progress with the gestational weeks. So these things, the particular disease knowledge, we need to have a very individualized and very good way to explain the patient counseling, because patient counseling is a really difficult task. Whatever we are going to speak, it has to have a repercussions after 3 to 6 months. So development, progression, and resolution of fetal arrhythmias, those things we need to also explain, not to make party or patients in a very other way around with anxiety. Rather, we can make them calm also. So premature constriction of ductus arteriosus, that we need to understand. So what are their eating habits, how they are going through, if after their removal of those things that can be prevented or not. Those things also we need to count down without explanation of very big things, that ductal arteriosus, constriction of ductal arteriosus can happen into a right ventricular constrictions later on, right ventricular small later on and all that thing. So restriction of foramen oval, restriction of foramen oval in the third trimester can have a normal implications also. But restrictions with foramen oval with HLHS can have a really great impact for the surgical things. So these are the things we need to, even with the TZA, with the restriction of foramen oval, needs immediate surgery basically after the delivery. So these are the impact of the diagnosis of your things we need to explain. So progressive cardiomegaly with high cardiac output states, these are also very important things. So these are the physiology can happen. So then cardiovascular profile score. So wherever we are seeing the heart drops with the heart disease. So what are the things like normal 2 points we can give, then -1 point with the ascites, pleural effusion and pericardial effusion, and -2 points if the skin edema has also happened crossing the ascites. So these are the things. Even the heart drops can be categorized into good, bad, and baddest. So these are the things we need to learn and explain the party. Like venous Doppler, umbilical vein, umbilical pulsation vein pulsations, that -2 with a total gap and all these things. And ductus venosus reversal with a -1 point, that we all know. But we need to see all these things, whatever, like something with right heart failure. So naturally, it will have an impact on ductus venosus. So we need to see the waveform of the ductus venosus pattern, and in that way we need to explain. Then the heart size and chest area, that has to be like normal is like 0.2, more than 0.2, less than 0.35. But if it is -1, like 0.35 to 0.5. So these are the most important points we need to see. Then -2, like 0.5. So cardiothoracic ratio can alter in many kinds of disease, even if not in a heart disease as well. So physiology of the heart has to be learned in a very good way. Then cardiac function, like normal tricuspid valve function and mitral valve functions, that is as to like fractional shortening, like more than 0.28. Though fractional shortening cannot be done in various kinds of machine, but with kind of very good machines right now, E10 and all, with HQ pattern, we can always diagnose with the fractional shortening. So cardiac function can be assessed in that way. So these kind of things like hollow systolic TR, it has got a really -1 point. Then hollow systolic MR is a more rather grievous prognosis basically. Then arterial Doppler, umbilical Doppler we know very well, but when it is diastolic absent is a -1, and if it is reversal, then it is -2 points. So these are all cardiovascular profile scoring. We need to go through all these things before explaining to the party. So whenever you are doing more parameters to establish that cardiac anomaly with their function, then you can make them more better decision. You can make them opt for a more better decision. As a doctor, as a clinician, it is our duty to do that. Then risk of aneuploidy with selected cardiac malformations, that Dr. Bhavana will tell. But I have gone through whatever the things, that is atrioventricular septal defect. Whenever you are taking decisions to continue, but you need to think about that, it is one of the highest anomaly in the cardiac, all kinds of things. It is almost 46 to 73% of the risk of aneuploidy that we need to think about. Then coarctation of arch and interruption, it comes to next. It's almost 5 to 37%. Double outlet right ventricle, it's almost 6 to 43%. So we need to learn what kind of double outlet right ventricle with less risk of aneuploidy, that Dr. Bhavna can tell more better. Then a hypoplastic left heart syndrome, though it is actually 4 to 9% aneuploidy risk, but there is a more risk of cardiac function dearrangement because it's a univentricular pathology. So it's really difficult to manage a univentricular pathology after the neonate burn, basically. So heterotaxic cardiosplenic syndrome, that may not be associated with any kind of risk, but heterotaxy can be associated with a bradyarrhythmia as well. So those things we need to consider. What are the things it is coming with actually? Then pulmonary stenosis, atresia with intact septum, that is PAIVS, almost 1 to 12%. Transposition of the great artery has got a very good prognosis because it is least associated with aneuploidy, and transposition of great arteries, if it is not associated with any kind of VSD, any kind of other things, then it has got a very good, good prognosis, because the surgery can be with a successful almost 97% survival rate to adulthood in the post-neonatal period. Then tetralogy of Fallot, again, it has got a very high risk for aneuploidy and very high recurrence rate in the sibling as well. As if somebody is having tetralogy of Fallot, the next sibling will have the 2 to 4% increase. Then the next sibling will have almost 8 to 16% of recurrence. That the way the tetralogy of Fallot doubles the risk for the siblings, basically. Then truncus arteriosus, it is one of the highest, almost 19 to 78%. Though the great vessel is one, there is nothing other than like two great vessels, and also aneuploidy risk. So we may take a decision for a termination in this kind of things. So our things has to be in a very easy way, whether we are going for the termination, whether we are going for the expectant. Then tricuspid dysplasia as well, as it is almost 4 to 16%. So estimated 22q dilation frequency, that is also very important to know. Interrupted aortic arch is the highest, basically. Ventricular septal defect is almost 10% overall actually. So we need to know that genetic has got a very important role playing before we sit with the patients. After genetics only we can sit with the patients with all kinds of parameters that I have already explained to you, with a good homework. Then you need to sit down with the patient. That is very important. Counseling is not an easy job. Rather, it is more difficult job than the imaging, because for the counseling, we need to have a lots of knowledge in every aspects, basically. Then truncus arteriosus is almost 35 to 40% 22q deletion. Isolated aortic arch anomaly, it's almost 25%. Double outlet right ventricle, though it is less, but it is less than 5%. And transposition is less than 1. So we can know what are the heart diseases are quite benign and what are the heart diseases can be malignant later on also. So current recommendations for fetal predictors for delivery planning. So duct-dependent lesions, we need to learn. There are two kinds of duct-dependent lesions. One is duct-dependent pulmonary circulation. Another is ductal-dependent systemic circulation. Pulmonary circulations happens where outer to pulmonary flowing ductal arch and reverse orientation of ductal arch if the inferior angle is less than 90 degrees. So duct-dependent systemic circulation, where it is happening, like hypoplastic left heart, wherever there is no flow at all. It may be hypoplastic left heart with the mitral atresia and aortic atresia. So there will be totally, the shunt is totally in the foramen oval is reverse. It is almost like left to right arterial flow across the foramen oval. So what will they need? They will need initialization of prostaglandin E1, because we need to pattern the duct while during the delivery. That is very important. Then only after that we can think of anything. So these things has to be explained to the party. That is very, very important. The patients has to be explained in a very good way. Postnatal, how we have to go for. We need to sit down with many kind of people like fetal medicine consultant who is doing the scan, the clinical genesis, the pediatric cardiologist who is going to manage the neonate later on. All people had to sit down in one table and had to discuss the various aspects. Then HLHS with RFO, that is restricted foramen of oval, the ratio of the pulmonary vein forward to reverse velocity time. So these are the things we need to go for actually. So plan for possible urgent interventions for the decompression of the left atrium. That has to be very much done. Then DTGA. DTGA is reported foramen of oval findings depends on a very predictive of restrictions like angle of septum primum less than 30 degree to the arterial septum. There are many kinds of things are there. How the foramen of oval, that is how much it is swinging towards the left atrium, that also depend on the restrictions. Even it will be totally closed, you cannot see the restricted, both the things, septum primum will be totally closed, like this ballooning of this things will be there. So these are the little bit of grievous outcome. So we need to think initiation of prostaglandin E1 suddenly after the delivery only. So pulmonary hypertension is a like detrimental factor in the DTGA that we need to clarify before the delivery also. So we can tell in the delivery room as well as the neonatologist to be prepared in that way. That is very important. Then tetralogy of Fallot with the absent pulmonary valve syndrome. Absent pulmonary valve syndrome is also associated with high risk of aneuploidies and all that. So before continuing the pregnancy, we need to think about many kinds of things. So lumps finding with the lower emphysema, so that we need to see about that. Ebstein's anomaly, whether it is associated with hydrospitalitis, uncontrolled arrhythmia, those things also we need to see. Though there are many kinds of surgical options are there by the pediatric cardiologist surgeons, but how much it is feasible for the patient, how much it is feasible for the baby itself when it is born, how much the baby's health can take up to you or take up it, those things has to count down. So there are many kind of TFEBR has got a very good prognosis. They actually go for a good kind of surgeries, but it depends on the what kind of TFEBR also. So considering, but the delivery has to be in a ECMO setup with a proper neonatologist. Then after that only the surgery can be decided. The tachyarrhythmias can be controlled well by the other kind of drugs like digoxin, sotalolol and all these things. Intrauterine therapy can be done. But complete heart block can be also be things for the delivery, and temporary pacemaker can be applied. Even in the certain kind of countries, they are going for the intrauterine pacemaker also. In India also, it has got a very good outcome, but complete heart block has got its own detrimental factors. How it is, the ventricular rate is in the starting when you are diagnosing, if it is like very, very low, like less than 40 or QRS interval is very, very less. So many other factors are there. So naturally that complete heart block will have a little have a bad prognosis. Even with the many kinds of even with the many kinds of SLE like anti-Rho, anti-La positive, they have also got a bad prognosis basically, the complete heart block. So these are the factors we need to consider, where the rheumatologist also many times sit down with you to counsel what kind of steroid you are going to have and how much is the dose and how the steroids is going to affect the baby, whether it is going to have the growth properly or not, how it is going to affect the growth, it may be a growth retardation also. So many things to counsel. So these are the very important thing we need to realize. So these are the overview of the cardiac diagnosis associated with chromosomal anomaly and grading of the heart defects according to the Allen Hogan. It is very well-known thing, the grading of the severity. So it will be very easy for you to go through. So that I have already explained you. So the congenital heart disease, if you are actually dividing according to the yield of the genetic test, yield, how much you are getting out of it actually. The syndromic congenital heart disease with extracardiac anomaly, that is de novo or inherited CNVs or SNVs, like CMA can yield up to 3 to 25%, and whole exome trio almost 25%, and genome sequencing can up to almost 41%. And non-syndromic and inherited CNVs, CMA it is unknown, but 31 to 46% in by the whole exome, and genome sequencing almost 36%. So these are the things also You need to sit down with the person like Dr. Bhavna, who is really, really competent with all these things, can explain you more better. And the sporadics can with the whole exome sequencing 2 to 10% and 10% with the whole genome sequencing. Sporadic means sporadic with the throughout the pedigree. It is all been given with a proper history, pedigree history, with the all kinds of genetic situations, association with the ultrasound. These findings has been seen. So the experience of strong interpersonal support is more important. Counseling is in easy to understand terms. That is very important. We cannot with the very difficult medical jargons and we are telling about ourselves and getting the credit. Not in that way. You have to sit down with your patient in their language. That is most important thing. Short time span between the congenital heart disease explained, diagnosed, and the specialist consultation. It should not take a lot of time that चलो आ जाओ 7 दिन के बाद मैं देखती हूँ, ऐसे करती हूँ 1 महीने के बाद. ऐसे नहीं होता है, because people are with tension. We have to have an empathy for the patients. As a clinician, I have always felt whatever maybe you are knowledgeable, but your empathy matters for the patient. That makes you a good doctor rather than a big, very knowledgeable doctor. So additional written information on the fetal congenital heart disease, links to appropriate online information also we can give. All people are knowledgeable. They go through the Googles, on the finger touch, they are having all the knowledge with there. So we can give them the practical knowledge. Counseling in a designated counseling room. That is very important. While doing, I'm scanning, I'm getting through something. Hey, बुला दो patient party को, ये बोल देंगे. इस तरह से, that should not be the way. It should be finished properly. Then it should be finished in a proper way in a designated counseling room. That has to be very important thing, so that the patient also feels special way, that I have been treated in a special way. Definitely. And address any language barriers. If you are comfortable with Telugu, Tamil, but the patient is speaking Hindi, then we need to have some persons who can understand Hindi and who can speak Hindi. That is most important. If I'm comfortable with Bengali, but the patient is something uncomfortable, something other language, I have to speak in his language only. That is most important thing. So elements of prenatal counseling in a nutshell, that is diagnosis, provide in description of diagnosis diagram depicting fetal echocardiogram findings compared with normal heart anatomy. Diagnostic limitation, uncertainties we need to explain. Even if we are uncertain, we have to explain our uncertainty to the patients. Then known causes of risk factors of congenital heart disease, we need to tell them. Potential for progression of the disease of the fetal demise, we need to explain. Extracardiac anomalies, we need to go through. Genetic associations, increased risk of congenital heart disease outcome, pregnancy options, terminations, or we are considering to continue. Fetal cardiac interventions options, that has to be. Delivery planning, timing, induction of delivery, site of postnatal cardiac care, all these things. Delivery planning, expected postnatal management, ICU management, intervention plans, prostaglandins, diagnostic testings, expected cardiac surgeries, catheterization procedures, expected hospital course, length of the stay, what to expect out of hospital discharge, medication, all these things, blah, blah, blah things we have to explain with the neonatologist as well. Long-term issues. What is kind of long-term issues? What kind of neurodevelopment occurring in this cardiac anomalies? Whoever the patients with certain kind of pulmonary hypertension or certain kind of very less flow with the great arteries and everything. So what kind of neurodevelopmental happening? We are only concentrating on that thing, cardiac anomaly, but it can have a long-term issues also. We need to explain those things. Family issues, other prenatal consultations and other things actually. So identified parental needs for counseling, parental emotional reactions we need to also tolerate and we need to go according to that. We should feel that somehow kind of family members have suffered. In that way, we can do the counseling. Extracardiac diagnosis, ethical issues, counseling for univentricular heart disease is very important. That I have already explained you, neurodevelopment and all. Fetal cardiac I already explained. So fetal interventions can be thicken of aortic stenosis and all that, but not yet in our country, but it can happen actually. So parental counseling in cardiac anomalies, dilemmas, actually it is completing the dilemma, diagnostic dilemma, evolving lesions dilemmas, fetal conditions dilemmas, ethical dilemmas, counseling dilemmas, genetic approach dilemmas, so many things. So just I am going to go for the small soft markers, certain kind of things, not even the cardiac anomalies, but you are going to counsel the patients in about these things. Late evolving anomalies, dysfunction, heart due to growth complications. Those also happens. So like echogenic foci and many things. So choroid plexus cyst, intracardiogenic foci, that has already been explained in ma'am's webinar. What is the likelihood ratio, how to explain, how to manage. Current guideline actually explaining about non-invasive prenatal testing if it is an isolated one only. Non-invasive prenatal testing after a good fetal echo. If we are finding it is a isolated echogenic foci, then we should go for NIPT. That can be Society of Maternal and Fetal Medicine guideline. So isolated VSD, how they have to be maintained. The outcome, this is a paper, brilliant paper. The outcome of prenatal diagnosed isolated fetal ventricular septal defect. Approximately, why dilemma? Because isolated VSD versus trisomy 21, it can be associated, and versus DGS syndrome as well, and versus with other aneuploidies, and spontaneous closure of isolated VSD. Where we are thinking about the genetic syndrome, that can be also spontaneous closure. So that's why it is a dilemma actually. So the size of the defect, if the VSD is less than 3 millimeter, the spontaneous closure can happen almost 15.8%. Sorry, it is about the remain patent during the first year of incidence of spontaneous VSD closure, right? So size of the defect, if the VSD is more than 3 millimeter, they are telling it can be also 71.4%. It depends on where the VSD is actually. The Palladini et al. Is explaining. The site of the defect, if it is mid-ventricular, it is 89% spontaneous closure. And apical muscular trabecular VSD, it's almost 84%. Anterior muscular trabecular VSD, almost 83%. So whatever it is a muscular trabecular VSD, it has got a really, really brilliant outcome. So we need to explain in that way, of course, after explaining the genetic association. Then spontaneous closure by type of the defect, membranous VSD and muscular VSD. Of course, membranous VSD, the closure is least actually, almost 22%. Then spontaneous closure rate by the follow-up duration in uterus within 1 year, that is almost 45%. So this is the way we need to explain. So these are all these things Bhavna will explain. And late evolving anomalies in cardiac anomalies, why we are concerned? Because it has got a natural course and in utero development as well. So naturally aortic stenosis, pulmonary stenosis, tetralogy of Fallot, coarctation of aorta. So those things can also happen. So we need to explain about the patients, and accordingly each individual heart disease had got its own way of explanation, own way of counseling. And it is one of the really, really difficult part actually. So we need to explain about all these things. So there are many kinds of things, exact guideline approach to the fetal echocardiography and many kinds of things. I hope almost 5760 we have SSKM, and more than that also, it is a previous data 1 year 6 months. Now it is almost 3 years over. So we have seen many kind of major cardiac anomalies, and in that setting also we have counseled many kind of things, and we have got with the genetic diagnosis as well, and counseled also with the, but you easily refer to the pediatric cardiologist for the other kind of counseling also, because it has to be always a one-to-one round approach for the patient. So prenatally congenital heart disease, chromosomal pathology we need to exclude, monogenic pathology we need to exclude, multifactorial, and typical congenital heart disease for chromosomal pathology. If it is yes, then conducting NIPT, chorionic villi biopsy or amniocentesis, whatever you prefer. Then chromosomal pathology is confirmed, then prenatal counseling, planned deliveries and other things. And if it is not actually, then you have to go for the termination and all. Thank you so much. Thank you, ma'am.
Thank you, madam.
Yeah, thank you. Hello.
Wonderful presentation, ma'am. Hello.
Thank you.
Thank you, ma'am.
Yeah. Thank you.
Thank you. That was a wonderful presentation.
Thank you. Actually, it's really big actually. So many things I need to.
Yes, ma'am. But
Yeah.
it was all very well explained, and especially empathy is the basis of counseling. Sympathy and empathy especially.
Very important. Very important.
The language as well.
Yeah, language, how we are throwing, how you are
Yes,
explaining, really important. Yes.
absolutely, ma'am.
Yeah.
Wonderful.
Thank you. Thank you.
Thank
so
you,
much.
ma'am.
Yeah.
Any doubts? Or in the chat box, any questions? Okay. Okay, ma'am.
Thank
So
you,
let's move on to the, thank you, ma'am.
Thank you. Thank you.
After the interesting talk, by Devasmita ma'am. Next, we'll move to Dr. Bhavna Agarwal. She's done her MBBS from Lady Hardinge Medical College, New Delhi, and she's a pediatrician and has done her MD at Kalavati Sharan Children's Hospital and a senior residency from pediatrics at AIMS, New Delhi. And she's done a DM in medical genetics in AIMS. And she's ex-assistant professor, medical genetics, Department of Pediatrics, AIMS, and published more than 20 papers and book chapters. Current affiliation is with AVP Medical Genetics at MFine Diagnostics, and field of interest is lysosomal storage disorders, prenatal genetics, and neurogenetic disorders. Welcome, Dr. Bhavna, ma'am. We're all waiting to hear from you.
Thank you so much, ma'am. Can I share my screen?
Yes, ma'am.
Yeah, just allow me a minute. Is my screen visible?
Yes, ma'am.
Yeah. So thank you so much, ma'am, for the kind introduction. And I think my talk is already it's going to be a summary sort of thing, because already previous speakers, Dr. Devasmita ma'am and Dr. Shinesh has gone through the genetics of CHD in a number of cases. So today we are just concentrating on one part of fetal cardiology, just the structural heart disease that we all know. There are n number of other things which involve genetics, like inherited arrhythmias, heterotaxis syndromes, cardiomyopathies, cardiac tumors. So since today's talk is just restricted to CHD, so I will be talking only about that. So before going on to the genetics, this particular diagram looks very complex, but it is very important to understand this, because you don't go into the numbers. Just see that this is on the basis of increasing resolution and decreasing the size of the gene. So if we go from chromosome to genes, we start with standard karyotype, then there is something called as chromosomal microarray, then there is something called as sequencing. So with this in mind, I will just tell about the sequencing. These terms we should be knowing before ordering or interpreting a report. We have heard about targeted gene panels, clinical exome, whole exome, and whole genome. So in research settings, whole genome is important, but in clinical practice, we should be knowing a difference between whole exome and clinical exome. We've already seen in the talk of Dr. Shinesh also that a dot in the ventricle can be just EICF, or a larger dot can be cardiac rhabdomyoma. So we all know that cardiac rhabdomyoma is associated with mostly tuberous sclerosis, and the genes are only two, TSC1 and 2. So in those cases, I can go for clinical exome, because as we understand, clinical exome is targeting only 5,000 to 6,000 OMIM morbid genes. So just focusing on those 5,000 genes, we decrease the cost, and you can get the diagnosis if the phenotype is very much forthcoming. But if the phenotype is something like a ciliopathy, one example was shown where a ciliopathy was suspected, so we should go for whole exome in those cases. So with this basic diagram, we all know that we've seen 3 cases of T13, 18, and 21 during the previous talk, and 2 cases of 22q11.2 deletion. So we all know that if we deal with aneuploidy or copy number variations, these are chromosomal causes, and the choice of test would be either your karyotype or CMA, depending on whether we are dealing with the aneuploidy. A karyotype will be able to pick it up. And if you're talking about rapid aneuploidy screening, because in pregnancy that is required, we can go for a FISH or QFPCR, right? Because that is a rapid aneuploidy screening. If we talk about a point mutation, we need to do a sequencing for that. It will not be picked up by CMA or any karyotype. So this particular thing is important, to have a rationalized use of a genetic test in the setting of a CHD. So this I can skip easily, because it has been already talked about. That CHD, why it is important is because it is the most common structural malformation, and as a proportion of GCA, which is the gross congenital anomaly, it is almost 1/3 of the proportion. And also, if we do proper management, the survival is almost 90%. So I am being a geneticist, I am not saying that you diagnose a CHD and counsel about termination. That is not the job of a geneticist or a fetal medicine specialist. This has already been talked about by Dr. Ma'am, that you have to tell, and the patient has to choose, because the fetus is hers, the right is hers, right? And the burden in India is very many. A lot of speciality in this particular branch is required, because almost 2.4 lakh
per year is the burden in India for a CHD. So benefits again has been talked about the importance of duct dependent lesions and the availability of prostaglandins and delivery at a tertiary care center. Also decision making regarding the continuation or termination, and also recurrence risk, as we would be seeing with a number of examples. Also the risk of recurrence would be dependent on the underlying etiology. So this one pie diagram we should always keep in mind when we diagnose a case of CHD. Like in the examples also, we have seen that even after doing extensive genetic workup, almost 56% of them, they'll be having no basis for having it. So it is because of gene to gene interaction, gene environmental interactions, polygenic inheritance and epigenetics, which is beyond the scope of a genetic test. And also not to forget environmental factors. They constitute almost 10% of the etiology. So a detailed history, depending on the 3-generation pedigree, the maternal history of the teratogens, and the maternal diseases, exposure to the infections, all that is very important. So I will not say, being a geneticist, just focus on the genetic causes. Be, aware of these environmental factors also, and the unknown etiology being the most common factor. Now moving on to the other part of the spectrum, which is the right side of the diagram, the copy number variations and the aneuploidy, which are the chromosomal causes. They are the most important when we are talking about CHD, because the etiology has an implication on the risk of recurrence also. And this particular thing has already been talked about, because we have seen 6 examples in the first trimester echo by sir, and we can see that almost 13% of them, they'll be 13, 18 or 21 trisomy, and monosomy X is also common. Almost 10% of them would have a copy number variation, and among that also deletion of 22q11.2 is the most common. And also important to note is the monogenic causes are very small in number, and among that also the ciliopathies and the chromatinopathies are important. So with this background in mind, the counseling should be like that the environmental factors and the unknown factors are there, and it should be told to the patient. So this particular pediatric cardiology paper, why I brought it here under the genetics of CHD is because what we are seeing in the prenatal life is almost 3 times of the postnatal study. So if you see this postnatal study, it had shown that when they did the etiology workup for the CHDs, 12.3% has a chromosomal anomaly, and when we diagnose prenatally, almost 33% of them, they'll have the aneuploidy. So why this difference in the proportions? Because in the prenatal diagnosis, some of them, they will be spontaneously aborted, IUD would happen, medical termination of pregnancy would happen. So eventually the postnatal cohort or the load cannot be replicated to the prenatal study. So there is a very important need to have data on the prenatal genetic cohort also, because whatever we see postnatally is not the same as the prenatal thing. So after talking about the CNVs, the aneuploidy, we should be not forgetting about this non-syndromic CHD, which is called as isolated CNV, because with a lot of genetics being done, a lot of genes are being diagnosed or discovered every day. And the genes which are involved are mainly in the transcription factors, cell signaling and adhesion molecules, cardiac sarcomeric protein, cilia movement leading to ciliopathies, and histone modifiers. Like we have all heard about the terms like Kabuki syndrome and the chromatinopathies. So in brief, chromatinopathies and ciliopathies are the important monogenic causes, the single gene disorders. And in chromosomal, you should not forget about the common aneuploidies, monosomy X and 22q11.2 deletion. So this is a complex diagram, but just to tell you that everything is connected, interconnected. This particular diagram shows the embryology, and we can see the role of GATA4, SSH, which is Senic-Hodge Hodge pathway, BMP2, 4, and all the cilia proteins and other pathways which are interconnected and lead to the disorder. So any mutation in any gene is known to cause monogenic CHD. So as already been shown, associated anomalies, very important to prognosticate, very important to have underlying diagnosis. So if the pattern recognition, the type of the CHD is very important. If we see extracardiac abnormalities are there in almost 20% of the cases, if we find a conotruncal defect, like we found in previous talk of CAT, which was there, a case of TOF, which was there, and interrupted aortic arch or right aortic arch. the possibility of finding a 22q11.2 microdeletion is more. So not to forget to screen for this, rather than just leaving the QF-PCR, we should go for CMA also to find this particular CNV. And also when we have a trisomy 21, there is almost 40 to 50% chance of having a CHD, underlying CHD, and the most common being the ABSD. And also it is the other way around also, 80% of the patients with CABC have trisomy 21. So this association is very important, and people are doing a lot of research why it is, more common in T21 than the other trisomies or aneuploidies. And when we find left heart obstructive lesions such as aortic stenosis, which can be evolving, which I have just learned, coarctation of aorta or HLHS, we should think of monosomy X also, Turner syndrome also. And not to forget, the DTGA has the lowest prevalence of the associated abnormalities. And after seeing this, DTGA has an association with maternal diabetes. So not just, not focus only on the genes or the chromosomes, talk about the patient holistically, the family holistically, the exposures, the maternal teratogen intake, all is very important. And associated anomaly is very important. The frequency of aneuploidy varies depending on the malformation. Not to forget these two particular things, heterotaxy and TGA. I am talking about just aneuploidy. Point to note, it can have monogenic causes. The heterotaxy can have single gene disorders. So when we're talking about these things, I'm talking about aneuploidy and the use of cytogenetics, which is in the form of CMA or QF-PCR. Okay, so as already been told by the previous speaker, Dr. Ma'am, that ABSD has the highest, percentage. I will not repeat the entire thing because it has been already told. So this diagram is showing the severity of the lesions. We all know that ASD, VSD, why it is important is for the counseling, these are very easily treatable. If you find a ASD or a VSD and the genetics is normal, the most common you would be surprised to know that the most common CHD in 22q11.2 deletion is VSD only. Though we talk about that TOF, if it is there, the conotruncal abnormalities, if it is there, you should think about 22q11.2, but the most common is VSD only. So if you see a VSD, you just don't leave it like that. Talk about 22q1.2 deletion in that also. And if it is normal, then the prognosis can be depending on the defect size and every other thing which has already been told in the counseling session. So syndromic association, these three, the top three, everyone knows, and we've already seen very beautiful examples of Down syndrome, Turner syndrome, 22q11.2 deletion. But not to forget these little rarer syndromic associations in the form of Williams syndrome. Yesterday only we saw a patient where we had pulmonic stenosis and hypertrophic cardiomyopathy, and it turned out to be 7q deletion in CMA. So these things are important because what we are seeing in the antenatal life is just the heart. We don't know about the neurodevelopmental outcome, the ID, autistic features, and all those things, endocrinal problems, which are going to be there in the postnatal life. So Noonan syndrome again is very important in terms of CHD. It can have a number of problems, and ASD, PS, hypertrophic cardiomyopathy. Kabuki syndrome, again, I've already told that chromatinopathy, single gene disorders, a number of CHDs are found, specifically HLHS and coarctation of aorta. So etiology will be dependent mainly on the type of the defect and the pattern recognition. So if we see this particular figure, this is a very beautiful figure, which is showing that when we have what kind of CHD has more of intracardiac single anomaly or intracardiac complex anomaly. If we see this diagram, TOF has the most common, finding of a single anomaly. So if we see this particular diagram, here we can see that DORV is the most common intracardiac complex anomaly. So why this is important is I am not a fetal medicine person. I don't know, the gray and the white things in the echo. But what I can see is when we find a DORV, the chances of finding other anomaly or the complex anomaly is more. So this particular thing is important to guide how the echo is finding things and to guide the counseling also. Likewise, if we see this particular diagram, this is showing the association of extracardiac abnormalities. And if we see here, it can very well show that VSD has a lot of associations, and among all, the CNS is the most common. So if we see this, CNS is the most common among all, and this particular thing is showing the postnatal and the prenatal agreement. So if we see here, the studies have shown that if it is a VSD, the postnatal agreement is 88%, and this particular figure is showing that VC, which was again shown in the echo, and TOF has up to 80 to 90%. So this is important. This particular case was a primary with fetus showing a CHD in the form of HLHS, which is hypoplastic left heart syndrome. There was no history of infection. Family history was also insignificant. NT scan was normal. Dual risk was low. So what next in terms of genetic testing? Definitely we have to rule out chromosomal causes and single gene disorders also, but not to forget that the mother was a case of phenylketonuria and was on irregular diet, and she was suffering from irregular levels of phenylalanine. So after ruling out genetics, we found that these causes are very important. This is again a genetic disorder, but here the fetus is not harboring the disorder. He is manifesting because of the maternal disorder, and this particular paper was age old. Why? Because now finding PKU is less common, and also finding uncontrolled PKU is again uncommon. So this paper was 20 years back, when they showed that depending on the phenylalanine levels in the maternal blood, the chances of finding a CHD is more. And you can see here that almost 12 to 18% of the patients, they turned out to have a CHD, and there was a increased propensity to have a HLHS or coarctation of aorta among that particular cohort. So this particular diagram, I just wanted to tell a complex counseling scenario here rather than the usual ones, because the usual ones, we all know that 22q11.2 deletion, it is a CNV which is very much common, almost 1 in 1,000, and to note is it is that much common that the patient's parents can be totally asymptomatic or mildly affected. So the counseling would be dependent on whether the parent is harboring the deletion or not, because the risk would go from less than 1% to 50%. So similar to that 22q11.2 deletion, there are other micro deletions also. One example is this 16p11.2 micro deletion, which is again, the parents can be totally asymptomatic. So here the need, I think the need of a geneticist is also very important here, because if we see in this pregnancy came with a fetus showing bilateral multicystic dysplastic kidney, VSD. They were counseled that there is a already affected sibling. The photos are here. The child has had obesity, autistic spectrum disorder, and when we probed, there was a history of a CHD which was operated at 2 years of age. The family was very happy with this child, because they said, okay, the child is doing fine. He has a near normal intellect, and they already lost a baby with a CHD at day 9 of life, and there was again an abortion. So they were happy. They continued the pregnancy. They said, okay, we told them that this can be a CNV, which was similar to this particular child. Unlike in the chromosomal causes, where we say that the chromosomal causes don't recur, but they can recur when either of the parents are a carrier. Similar cases can happen in 22q11.2 deletion, where by dictum it is said that you screen the parents even if they are normal. So here they continued the pregnancy, and unfortunately the mother was carrying the similar deletion, but she was asymptomatic, because there are factors which depending on which the penetrance of the defect would be there. So they continued the pregnancy. However, the baby was born, and the baby died immediately after 1 month of life, because the severity of the CHD was different. The CHD which was there in the first baby was not similar to this baby. The first baby had a DORB which was operated, but this baby had a pulmonary atresia, and also duct dependent lesion, and also surgery was difficult. So this particular baby had a different spectrum of the disorder. So counseling here is very important. The spectrum has to be told. The survival rates and the associated anomalies has to be told. It cannot be replicated. There is a lot of intrafamilial variability which has to be told, specifically in copy number variations. So challenges in counseling has to be dealt that way. So this particular diagram is showing just the appropriate test. This has already been told. When we have a cardiac or extra cardiac phenotype, family history has to be taken. Previous genetic testing, including prenatal testing, has to be reviewed. And if you're suspecting aneuploidy, go for a karyotype or a rapid aneuploidy test like QFPCR. If you're suspecting DGeorge, like I've already told in cases of conotruncal abnormalities, or pulmonic stenosis, they're suspecting Williams, go for a FISH or CMA again. Or if you're finding a lot of extra cardiac abnormalities, again, the chances of finding something chromosomal is more, so go for chromosomal microarray. However, if you're finding a pattern if you're finding polycystic kidneys or again with CHD with occipital encephalocele, I know it can be a spectrum of a celopathy. So I will not waste my money on, going for CMA or karyotype. I'll straight away go for a whole exome sequencing in that. So targeted sequencing has to be done in those cases. Again, here the importance of geneticist is important because we cannot terminate a fetus on the basis of a variant of unknown significance. We have to do in-depth analysis to prove whether this variant is actually pathogenic or likely pathogenic, or a functional analysis has to be done to dissect that particular variant. So with this, I would end this genetics in CHD. So thank you for patient listening. Hello.
Hello, ma'am.
Hello.
Hello, yes, ma'am.
Thank you, Dr. Bhavana. Is it done? Or it stopped
Yes,
midway?
Yes, ma'am. It's done, ma'am.
Done? Okay. Thank you very much. I think it was very elaborate. Thank you very much for elaborate genetic counseling and cardiac anomalies. Do we have any questions in the chat box? No, I don't. No?
No,
Okay.
ma'am.
Right. We can wind up, Dr. Radhika.
Okay, ma'am.
Thank you.
Thank you so much, Dr. Bhavana Agarwal. That was a wonderful session. Thank you for enriching our knowledge. And all these were practical as well, because we are left with so many choices of investigations and we do not know to choose. So your clear explanation and description of the various tests and with the illustrations has guided us actually. So we will get back to you if we have any doubts.
Sure, ma'am. Sure.
Thank you, Malati ma'am.
Thank you. Thank you very much. Thank you.
Webinar, and thank you so much, all the delegates for attending this session, which is very important to our practice, day-to-day practice. And thank you, organizers, Tnfog organizers, Dr. Sampath ma'am, Dr. Ramani ma'am, Dr. Malati ma'am, and all the speakers, Dr. Manigandan sir, Dr. Sirish sir, and Dr. Devmishmita ma'am and Dr. Bhavana Agarwal. Wonderful presentations, and you've all enriched our knowledge and inspired us as well to take up this fetal medicine specialization and to help our patients in a very good manner. Thank you. We'll wind up the session. Thank you, Sahiti, for your support.